Hello and welcome to this session. I'm James Wilson, I'm the chair for this session. I'm Professor of Philosophy at University College, London. So I'm delighted to be able to chair this session, which is going to focus on the lessons that we can draw from historical and philosophical thinking for post-pandemic societies. So the next 2 hours are going to provide a rich discussion of how philosophical and historical standpoint might help us to prepare for the post-pandemic period. Well, I'm delighted to have 4 very distinguished discussants. There's Professors David Jones, Frank Snowden, Ray Langton, and Alexander Bird. I'll say a little more to introduce each speaker as they give their initial contributions. So just to give you a flavour of what we're going to be covering over the next couple of hours. So we'll be discussing what a genuinely post-COVID world would even mean and whether it in fact will ever happen. Well, this worry about how to demarcate the post-COVID world is perhaps well exemplified by the history of this particular summit. As you may know, it's in fact been twice delayed. So it was first scheduled to run in November 2020, and then it was moved to 2021 before finally finding its home this week. So the post-COVID has been continually deferred so far. We'll also be discussing how to count the costs and the benefits of the often draconian disease control policies that were adopted, such as stay-at-home orders. Should we be willing to spend more to save a statistical life from a pandemic disease than we are from, say, cancer or air pollution? Should such decisions be a matter for politicians alone or for citizens as a whole? We'll also be talking about the role of social trust and trustworthiness. So the pandemic occurred at a time when rising inequality, cultural polarization, and poorly regulated social media, and also the presence of active campaigns of disinformation had arguably already created a crisis of trust and of truth in the public sphere. Trust is fragile, and it's much easier to lose it than to get it back. So one of our key questions will be whether a healthy public sphere can be re-established, and if so, how? Lastly, we'll be considering the long-term mental health impacts of previous impacts and the reasons for thinking that this pandemic may also lead to a long tail of mental health impacts, which many countries may be poorly equipped to deal with. So I'll introduce myself now briefly. So my own research focuses on ethical issues in healthcare and in health policy and on the ownership and governance of health information. So I provided ethics advice to a range of public sector organisations in the UK as part of the pandemic response, especially as a member of our National Data Guardians panel. I brought together a lot of my work in a book last year, which was called Philosophy for Public Health and Public Policy, Beyond the Neglectful State. But for my sort of contribution, or perhaps just to call it a provocation, I want to mention something good that we might be able to take away from the pandemic. Good, that is, at least from the perspective of people like me, who have been long arguing that states can and should do more to protect health by removing health threats from the environment. If you think back to what probably seems like a very long time, back to before 2020, you'll immediately notice that our previous expectations about how states can and should intervene in citizens' daily lives to protect health have been profoundly reshaped by the pandemic. So, for example, in the world before 2020, even non-intrusive measures such as minimum unit pricing for alcohol or regulation of wood-burning stoves were rejected in England and the UK as involving too much state interference. Since then, vastly more intrusive measures, including travel restrictions, mask wearing, vaccine mandates, and of course lockdowns, have not only been legislated for, but enjoyed widespread compliance, apart from by our Prime Minister. So, rapid and radical change provides an excellent opportunity to reflect on our previous practices with a fresh set of eyes. So, what should be taken forward from the more muscular approach to public health that's been shown over the last 2 years? Does the pandemic have profound lessons to teach us about the nature and the place of public health in society? Or should we treat the pandemic periods as a state of exception, as a special and discrete time that was subject to its own set of ethical principles with few implications for the ethical justifiability of public health practice post-pandemic? Well, of course, there's some reasons for skepticism about the idea that we can draw straightforward ethical lessons. The last 2 years have seen societies on a public health emergency footing for large stretches of time. Now, it's often argued that the ethical principles which apply to emergencies are different from those which apply to ordinary circumstances, or at least that the balance of such principles is different, favouring an approach that's more utilitarian in an emergency, so that, for example, rights and safeguards that might be applied under usual circumstances would then be temporarily lifted. However, I think it's too hasty to think that public health emergencies have nothing to teach us about the ethics of public health in ordinary circumstances. The story of public health responses to COVID has not just been one of bold and decisive strokes by governments, or failures to take such bold and decisive strokes. It's also been a story of countless actions by millions of peoples which have either slightly reduced or slightly increased risk to others. And if you think about it more closely, sometimes the effect of a government intervention, such as, for example, the dissemination of new public health guidance, sometimes the effect of just that guidance just is the sum total of these small individual effects. For example, one person shifts a meeting online as a precaution, or another person refuses to wear a mask on public transport. Now, even in the context of a public health emergency, each small act of precaution will typically have correspondingly small effects. Nonetheless, the aggregate effect of all these actions together may make all the difference in the world. So I think that the point we need to take forward is that large-scale public health problems rarely come out of nowhere. The myriad of small actions taken by many, many people shape the environments in ways both positive and negative to population health. And these individual actions are not separable from the scale and the severity of the public health problems that states face. Thus, public health problems that have socially controllable causes, but have been allowed to fester and to have become part of business as usual, shouldn't be treated as any kind of a baseline from which deviation must be justified. We can and we should just question, for example, whether governments will have done enough in public health terms if the net result is that a similar number of people die each year from COVID as do in a bad flu season. Pre-pandemic, too many people work with the default assumption that it might be acceptable for the state to do nothing to protect and promote population health, and whatever it was that states did do needed to be checked carefully to ensure that it avoided both paternalism and state overreach. In the UK, following Margaret Thatcher, this has often been popularised with the idea of the nanny state. Now, in my recent book, I argue that this is to get things entirely backwards. It isn't the nanny state that we should be most worried about, but the neglectful state. And the neglectful state is one which fails to pursue cost-effective and proportionate measures that would make life safer for all, and in so doing shows a callous disregard for the lives and well-being of everyone, but especially the vulnerable. Now, neglectful states are not ethically problematic just in emergencies, but in ordinary circumstances too. So if we're going to take forward one piece of moral learning from the pandemic, I would suggest it should be this. It's indefensible both for governments and for private citizens to resist measures that are mildly inconvenient for them, but which would prevent things becoming much worse for many others, especially when these mildly inconvenient measures would prevent hundreds or even thousands of deaths. This was true even before the pandemic, but in the circumstances of the pandemic, I think it briefly became obvious. A crucial question is how to prevent ourselves from forgetting it, how to keep it salient, even in the circumstances of post-pandemic business as usual. So I'd like now to introduce our next speaker, who's Professor David Jones. So trained in psychiatry and history of science, David Jones is Professor of the Culture of Medicine at Harvard University. His research has explored the causes and meanings of epidemic health inequalities and decision-making in cardiac therapeutics. He's now pursuing 3 new projects on the evolution of coronary artery surgery, on heart disease, and cardiac therapeutics in India, and also on the threat of air pollution to health. He teaches the history of medicine, medical ethics, and social medicine. Professor Jones's title is, Will We Ever Be Post-COVID? Thank you, and take it away, David.
Yes, I hope my slides are up. I want to thank James for that very interesting and thoughtful introduction, and for being the first person I've heard so far at this conference to mention the obvious irony that we are taking part in a post-COVID summit, even though we are not yet post-COVID. This raises the obvious question, will we ever be the post-pandemic society promised by the title of our session? And I'm not sure. Human societies have, of course, endured countless epidemics throughout history. Most of them have indeed ended, and I think we can take some solace in that historical fact. But the ending is not always a decisive event. In the brief time I have, I will discuss a series of historical precedents to try to understand the different ways that epidemics do or don't end, and I hope that this will help us to imagine possible COVID or post-COVID futures. Now, historians, like everyone else, became interested in COVID early in the pandemic, but we have not always agreed about what we could contribute to the global conversation. Consider two articles that appeared in the first week of March 2020. I wrote one of them, a short piece in the New England Journal of Medicine, that made the basic historical argument, basically channeling the work of Charles Rosenberg, that we can indeed learn from history. Past epidemics have often followed a classic trajectory of rise and fall. Societies often respond to the crisis with blame and stigmatization. Responses are usually politicized and often racialized, and it was reasonable to expect that similar things would happen with COVID. Many historians also joined the guessing game of trying to predict whether COVID would be more like SARS, which was quickly contained with low mortality in 2003 and 2004, or like influenza in 1918, a disaster that claimed 40 million lives worldwide. In all of these conversations, historians assumed that historical analogies would offer valuable insight to our current dilemma. But other historians took a different perspective. This article also appeared in the first week of March in 2020. Writing from his vantage in Hong Kong, historian of medicine Robert Peckham warned against the temptation of simplistic analogies. He did not think that meaningful conversations could even be made between COVID and SARS within Hong Kong, two epidemics of similar viruses just 16 years apart. As he argued, not only were the viruses themselves different, but Hong Kong itself had been changed in the intervening period in ways that made any comparisons misleading. Two French historians took this further. They criticized historians who tried to define universal features of epidemics and to draw lessons from that history. As they wrote, embroidering the present crisis into a quasi-mythical structure of panic and quarantine has the effect of smoothing over the intricate historicity of pandemic events. Historians need to resist the comforts of comparison. I've now been thinking about this question for 2 years and have not reached an easy resolution. I certainly understand the caution of historians who warn against facile comparisons between past and present. But the resonances between COVID and past epidemics have often been uncanny, and it seems foolish to set aside the lessons of history altogether. By May 2020, just 2 months into the epidemic, at least in the United States, historians began to be asked how the epidemic would end and how society might be changed. And to answer this question, we had no choice but to look to historical precedents. One of the ironies of this article is just as this summit itself has been postponed repeatedly, the New York Times keeps rerunning this article as if it's a new article because this question, how will COVID end, unfortunately remains as relevant now as it did when this article first ran 2 years ago. And so for historians to answer this question, how will this end, we have no choice but to look at historical precedents. Even a quick review can show that different epidemics have ended in very different ways. The best case scenario, of course, is eradication. This was achieved most famously with smallpox. Unless an error is made in Atlanta or Moscow, no human will ever suffer smallpox again. But it's important to understand that it took humans 180 years to achieve this success after the development of vaccination. And this success has not been matched with other diseases. World Health Organization tried and failed to eradicate malaria in the 1960s. Guinea worm and polio have nearly been eradicated, but it remains unclear if either of them will actually be fully eradicated for a variety of different reasons. The worst case scenario is for a disease to become a recurring problem, and this has happened with influenza. After its 1918 pandemic, flu has never really disappeared. Because of its widespread animal hosts, pigs and birds, and because of viral drift and shift, flu circulates every year. Every few years, a more serious strain emerges. None of these subsequent strains have been as dire as what happened in 1918, but that risk exists. And one of the interesting things about these two graphs of flu is you can obviously change the scales to make very different points. If you look at the graph in the top center of recent flu pandemics, it makes it look like flu has been a big problem year after year after year, except last year when there was very little flu because of COVID. But if you look at the full historical sweep, where you include 1918 on that plot on the lower left, it makes it look like flu has significantly diminished in magnitude over the past century. It certainly has diminished in magnitude, but depending on how you count, it kills roughly 50,000 people each year in the United States. Flu remains a significant problem. A third option is for disease to persist, but at lower levels or in more marginalized populations, such that it fades from public consciousness. And this is a bit of a problem of the neglectful state. And this has happened with both tuberculosis and HIV. HIV has been partially controlled, especially in wealthy countries, but it continues to cause immense suffering elsewhere in the world. Tuberculosis is no longer a leading cause of morbidity and mortality in Europe and North America, but it is on a global scale. Both diseases could be attacked more aggressively, and this could substantially reduce their prevalence, but the needed political and social will has not yet been mobilized. And a fourth option is probably demonstrated by COVID's closest relative, SARS-CoV-1, which has disappeared from humans after running its brief but dramatic course in 2003 with about 8,000 cases and nearly 800 deaths. But even though there hasn't been a human case since 2004, World Health Organization officials assume that it persists somewhere in nature, in whatever animal hosts first fostered it, and it could always break out again. And even if we do contain the current version, SARS-CoV-2, that could be a likely scenario. It would disappear back into the human hosts that first gave rise to it, lingering and waiting to strike again. So which path will COVID follow? It's obviously far easier for historians to describe past epidemics than predict which ones best predicts COVID's future. And any prediction that anyone gives now must be taken with a huge grain of salt, since most COVID predictions over the past 2 years have proven to be very, very wrong. The basic problem is that no one anticipated the complexity of the COVID pandemic, or at least no one that I've come across. You know, when historians and epidemiologists were asked in May 2020 how COVID would end, the basic question was whether there would be one wave, as often happens in pandemics, or several. Flu, for instance, in 1918 famously had 3 waves and then largely came under control. Everyone 2 years ago assumed that the pandemic would run its course over a few months or maybe over a year, and that's why the post-pandemic summit was first planned for November of 2020. But if you look at those predicted wave scenarios made by 2 of the United States' best modelers, Mark Lipsitch and Mike Osterholm, none of those scenarios resemble at all what we have actually seen. COVID has defied expectations. Even as the first wave faded 2 years ago in Wuhan, Milan, and New York, COVID surged elsewhere. The pandemic has now spent 2 years shuttling around between different global communities. With so many people infected worldwide, the pandemic has been able to rapidly generate new strains, with India suffering the first wave of the Delta virus in April 2021, North America and Europe suffering Omicron this past winter, and now BA2 on the loose, causing havoc in different times, different places. And it's very peculiar to see the worst impact of this epidemic 2 years into it. And a lot of forecasters have simply given up. A recent piece in the New York Times talked about many possible directions that the epidemic could go, but didn't want to make a strong case for any of them. Tony Fauci and his collaborators recently cited the problem of disease complexity and concluded that we might never achieve herd immunity. The COVID virus is too unstable, the infected population is too large, and we might face an ongoing struggle against an endless supply of new strains. So why did we fail to appreciate this complexity earlier? There are 2 basic explanations. One is that past pandemics have been equally complex, but historians have not understood them well enough to recognize this. That is certainly possible. It's quite difficult to reconstruct in full detail what really happened with flu in 1918, let alone with plague in 1347. The other explanation is that COVID actually is far more complex than past pandemics. For instance, because human populations are far larger and more complicated than they were in the past, and this has created new ways for viral pathogens to cause trouble. So we seem to be on uncharted ground. This weakens the power of historical precedents. Presumably modelers are already hard at work. I can imagine the calculation. You take the size of the infected population, multiplied by the virus's mutation rate, to predict the rate at which new strains will emerge. Could that process go on forever? Are there limits beyond which mutant strains will lose their virulence? Will humans get to a point at which we've been exposed to so many different COVID variants that sufficient population immunity does emerge? This will depend on the ongoing interactions between viral evolution and social response. Even if the future is uncertain, we do have the power to influence it. And so while we grapple with ongoing COVID variants, we should never forget the most basic lesson of history. It is inevitable that entirely new pathogens will emerge. We might be post-COVID someday, but we will never be post-virus altogether. Thank you.
Thank you so much. That was a fascinating opening. I'm going to pass now to Alexander Bird. Before I do that, I should mention for all those in the audience, we'll be very keen to take your questions and comments later. So that if you have anything that you'd like to add, either do put it in the chat, or you'll see a Q&A button as well, where you can ask a question via that, and we'll come to those questions once all the discussants have said their initial piece. So that it's a great pleasure to introduce Alexander Bird next, who's Bertrand Russell Professor of Philosophy at the University of Cambridge and also a Fellow of St John's College. He's published widely in the philosophy of science, metaphysics, epistemology, and philosophy of medicine. His books include Nature's Metaphysics, Thomas Kuhn, Philosophy of Science, and the forthcoming Knowing Science. And his title is going to be Counting the Costs of Combating COVID.
Great. Thanks very much indeed, James. So one feature of the post or COVID, if it is post world, will be thinking about how to deal with the next pandemic, or a future pandemic that looks roughly like this one, or as if it might be this one. And so one of the things we have to think about is what lessons do we learn from the way that we have handled the existing one. And what I want to suggest is that we haven't made a very good job of it in handling the existing pandemic. And I'm going to take a focus that is I'm afraid, basically on the UK, but I hope this will be a useful sort of model for thinking about how other nations have responded. And then I'm going to sort of look at things a little bit more globally right at the end. Because most Western nations, but certainly not all, took an approach that's roughly in the same ballpark as that taken by the UK, sometimes more successfully in certain respects, sometimes less so. Okay, and I want to talk about how we assess what a good approach to handling a pandemic might be. How should we assess what a good approach is? And one of the things I'm going to argue is that we've just taken far too narrow a view of what counts as doing well. Okay, so I'm going to start off by thinking about the costs of the approach that we took in the UK, and I'm going to start by talking about the financial costs before broadening out my perspective. The costs of the UK's policy towards COVID is well over £400 billion, as estimated by the IMF. So we're talking towards 450 billion euro. So what has that achieved? Well, if you take the worst case predictions about the numbers of deaths that there are going to be in the UK, probably an overestimate, which was going to be 510,000, and subtract the number of actual deaths, 156,000, we get a figure of the number of lives that this policy has saved. I mean, remember, the worst case scenario was like if you did absolutely nothing at all, which is never really going to be the case. So at maximum, our policy saved in the region of 350,000 lives. And so if you do the math, as they say, it turns out that we spent £1.15 million, roughly 1.4 million euros per life saved. The average age of people dying from COVID was 80.4, and people at that age could generally live for another 8 or 9 years. So rough estimate suggests that we spent £132,000, 158,000 euros for each year of each life saved. So, I mean, was that money well spent? Well, one way of getting an answer to that is to look at how our government and our health service decide to when to spend money on other health interventions. And we use this quality methodology whereby we look at the amount of money spent in effect on one year of high quality life. So in assessing, for example, whether a new cancer drug is good value for money. And the threshold above which we won't invest in that, won't supply drugs, is in the region of 20 to 30,000 pounds per quality, that is to say, per year of high quality life. So we're spending in the region of 5 to 6 times as much on saving COVID lives, and probably those lives were not of the highest quality, given that they're octogenarians in most cases, than we would on preventing, say, a young person dying from cancer. So from that perspective, we have not done very well at all. We would have done much better to spend this money on something else. Of course, there are many things that could have been, but that gives you a sense of how far from being an effective policy ours, in fact, was. Just think about it another way. The amount that we spent on the pandemic is the amount that we spent on the National Health Service in the UK in 2.5 years. Right. So to recoup this money from the health budget, we would just shut down our National Health Service. No medicines, no treatments, no operations for anyone. Sack all the doctors and nurses for 2.5 years. What would the health consequences of that be compared to what we've saved in the pandemic? Okay, so of course, what I've mentioned so far are the costs of the COVID response just to the Treasury, and so to public services and to taxpayers. Of course, rather greater possibly have been the costs, the non-financial costs, or costs borne by people rather than the Treasury in many forms. So while the COVID response aimed to protect us from COVID, it also led to a reduction in health and well-being in other respects. For example, the number of hip replacements halved from roughly 100,000 to 50,000 in the UK. I mean, that's 50,000. The hip replacement is an extremely cost-effective way of preventing immobility and immense pain. 50,000 operations not carried out is just one tiny, it's extremely significant, but it's only one tiny part of the effects of this policy. And of course, to this, we should add many other operations and procedures not carried out, as well as increased impairment on mental health, and quite widespread problem about which we'll be hearing a bit more later, rise in domestic abuse, devastating effects on education, careers blighted and opportunities lost, and the degradation in quality of life that many felt in simply not being able to do the things that give their lives meaning, such as being with family and friends. And moreover, these costs have fallen most heavily on the most disadvantaged in society. So the widening of the inequality gap in education has been significant and is well documented, but that extends to other public services as well. So why did we take this approach? Approach that really focused on just one thing. It was focused on, as far as possible, getting rid of COVID. It was all about COVID and what we could do to get rid of COVID, and other problems, consequences, the sequelae of the COVID intervention were to be dealt with separately by further expenditure. So it was an extraordinary feature that in this country our policy was largely set by the government's Scientific Advisory Group for Emergency, SAGE, drew up the policy that required all this expenditure. But who were these people? Of the 23 individuals attending these meetings in March and April 2020, 18 were medics or biomedical researcher. Another was a statistician. 2 were researchers into behavioral responses to health risks, and 2 were Downing Street political advisors. There was no one who could speak to the consequences of the proposed policies for any other aspect of life other than the disease itself. There weren't even any senior civil servants present who might have been able to give a wider perspective. The sole focus was on combating the disease. So this is an emergency kind of response, which is, it has this kind of institutional salience bias. There is only one thing that we're focusing on, and we're simply ignoring everything else, putting it aside to be dealt with later. Now, I mean, so another thing that I think that was going on was that I mean, salience bias is just one form of a number of the cognitive biases that were at play. And another was, I think, as it were, our unwillingness to engage in the hard thinking that is required in order to deal with and make decisions concerning incommensurable value. So that's to say, this is the phenomenon when we have quantities or values or whatever it might be, standards that lack a common measure. And without a common measure, it's difficult to prioritize. But my argument has been really that when in deciding to implement, for example, a lockdown, policy makers need to weigh avoidance of an increase in mortality against an increase in domestic abuse and against detriment to children's education, mental health, and so forth. But how on earth does one do that? How much domestic violence is equivalent to the death of an 80-year-old? Now, it sounds callous even to raise such a question, but of course, you have to raise such a question. Such a question must be in the minds of policymakers if they are to make the best policy decisions. So the quality methodology I was talking about earlier is a means of providing commensurability in healthcare contexts, but it hasn't been extended to enough, I think, to other contexts. And it's difficult to see how it can be. It's difficult. These problems are imponderable in the strict sense that we can't weigh these harms against each other. And so one of the biases that I'm talking about is that since it's so difficult, we tend to put these questions to one side and to deal with them separately. But I think that's simply bad policy making. one has to consider all the costs and benefits of a policy, even if they are in fact incommensurable. And that's why policy making is so hard. So I'd like to conclude by remarking on the thought that one of the problems here, I think, is that we in Europe and North America you have really two schemas or two mental models of infectious and transmissible disease. One is centered on the paradigm of common cold or flu in a healthy individual, basically a mild disease which is at most unpleasant, but generally not a matter of great concern. And the other one, the other model, sort of sees disease as foreign, deadly, and very frightening. You might think of Ebola, or we might have some historical memories of smallpox. But yeah, a combination of good public health and vaccines has largely eliminated endemic infectious diseases from the West. So all the things that were once common in Europe, smallpox, rubella, polio, measles, TB, and so forth, are mostly almost entirely a matter of history here, although TB is making a bit of a comeback. So we don't really have a model in our minds of a serious endemic disease available to us. Of course, if you live in Africa, you absolutely do have models of serious endemic diseases. Malaria, for example, kills more than 400,000 people each year, the majority of whom are children and pregnant women. So it's estimated, I mean, this is an absolutely startling fact, that's estimated that the disruption to malaria control in sub-Saharan Africa caused by COVID-19, so this is the disruption to malaria control caused by COVID-19, that brought about more additional deaths from malaria than was directly caused by COVID itself. So the worst effects in Africa of COVID weren't COVID deaths, they were malaria deaths. Right. Certainly malaria is not unique. HIV/AIDS is the most lethal transmissible disease in Africa, killing twice as many as malaria. Diarrheal diseases kill about the same number as malaria, and so forth. So Africans therefore have available to them many models of dangerous but endemic diseases. It's one of the reasons, but certainly not the only one, why Africa's fared relatively well, because actually many African countries have quite good community health systems precisely to combat these kinds of diseases, which were readily turned to helping with COVID. So I think that we should, of course, that one contemplates serious endemic disease. Isn't that mean one should always accept such a state of affairs? Now we've heard about the possibilities of eradication and how difficult it has been. For any disease, there's a question about whether eradication is a realistic possibility at what cost. But there is some prospect of eradication of malaria if we are willing to spend the money. So it's been estimated it would cost about 140 billion pounds to eradicate malaria completely by 2050. So we compare the numbers, okay? So the UK government spent over 400 billion pounds to prevent fewer than 400,000 COVID deaths. Whereas for a third of that cost, we could eliminate malaria entirely, which kills that number every year. Yeah, so that's a comparison to finish with. So I think some of the lessons to think about for our post-COVID society will be, this is the last thing I'll say, is we mustn't enter emergency mode of thinking. We can't focus on just one thing. We have to consider all the costs as well as benefits of any interventions we decide to make. We have to think hard. We have to make choices amongst what seem to be incommensurable values. We can't just ignore those hard questions. And we need to take a global perspective, which includes recognizing that the social nature of disease means that COVID or whatever follows from COVID and comes next is not necessarily the same disease in all places and all times.
Thank you so much for that. That's an excellent provocation. I think we're going to have a very rich discussion when we get to it very shortly. And so that next I'd like to introduce Ray Langton, who's a Knightbridge Professor of Philosophy at the University of Cambridge and also a Fellow of Newnham College. She's published widely in moral and political philosophy, history of philosophy, metaphysics, philosophy of law, speech act theory, and feminist philosophy, with a central focus being on speech acts and social justice. So her books include Kantian Humility, Our Ignorance of Things and Themselves, and Sexual Solipsism, philosophical essays on pornography and objectification. So Ray's title today is Trust and Tragedy in COVID Times.
Thank you very much, and thank you very much for the opportunity to speak on this panel. It's going to be a great discussion afterwards, I know, as well. So we're asked to bring some philosophical perspectives and perhaps some historical perspectives to the questions of COVID and the post-COVID era, if there ever is such a thing. And I want to talk about trust and tragedy in COVID times. And I want to bring out the way in which the tragedies of COVID have been entwined with gross abuses of trust and gross breakdowns of trust in both the personal and the political domains. I want to bring to this the perspective of feminist philosophy, which has said for a very long time that the personal is political. That is to say, the supposedly personal sphere where people live in the context of their families, their friends, those with whom they're most intimate. These spheres all have political dimensions. Our personal decisions, our supposedly personal decisions that we make simply expressing our own choices, our own autonomy, these have much bigger political implications. And I want to show how the personal is political in how the COVID times have affected us already in two areas. In our intimate relationships, in the private domain, and also in the way in which information has affected our individual choices, information and misinformation in particular. So trust and intimacy is one of my questions. Trust and information is another of my questions. I'm no historian, but I'm also going to remind you all that trust is, of course, not a new problem. One thing that Honora O'Neill has said about a different topic is that the problem is not a lack of trust, the problem is a lack of trustworthiness. And this is true in both of the areas that I want to talk about. Honora O'Neill was commenting on manipulations of the media in elections and referenda. We've seen historically gross breakdowns of trust and gross abuses of trust in the banking crisis, in elections and referenda, but they have worked out in a slightly different way, I think, in COVID times. And in particular, in the intimate sphere, one thing that COVID did was open up a whole new side, or at least exacerbated an existing problem with breakdowns and abuses of trust in intimate and family settings. Alexander Bird has already mentioned that in COVID times, the level of domestic abuse went up dramatically. The level of sexual abuse of women in the home went up dramatically. There was a BBC Panorama documentary that said that 2/3 of women in abusive relationships have suffered more violence from their partners during the pandemic. And of course, one thing about lockdown, first of all, was that it put these women in the power of their abusers. And secondly, it made it impossible for them to get help from outside. So 3/4 of the victims of abuse also said that the lockdown made it much harder for them to escape their abusers. There are many other aspects to the personal situation of women that was made dramatically worse during the pandemic. The at first, it seemed as though the level of caring responsibilities would be shared more equally when the fathers of families were home as well. And that did seem to be the case for a little while, but it soon reverted. But the ongoing level of care work that was inflated for women due to the deprivation of childcare and school resources, with the closing of childcare, the closing of school resources. This is part of an easily missed tragedy of the lockdown period, and it's one thing that we will need to keep track of in the future. It's not just women, it's of course the children themselves, and Alexander Bird talked about this too. Educational opportunities have been so damaged through the COVID period. And I want to talk about a very, again, personal side to that, where in the personal and private setting of their own home, the sexual abuse of children has also been increased during the lockdown period. I have seen data from Australia that said that the Australian Federal Police used to get 776 reports a month on abuse of children, where offenders are encouraging the children to self-produce online exploitation material. With COVID, with the children being unsupervised at home, being put to entertain themselves online, and with the abusers and the potential abusers having an open and free hand, the Australian Federal Police said that from 776 reports per month, and Australia is a relatively small country, as you know, the calls then went up to 1,731 reports per month during COVID times. So the data on the kind of abuse of trust in intimate settings, in the setting of the home, and the implications for the private sphere of the COVID pandemic are something which is much less visible than a lot of the other things that we want to talk about. And in post-COVID era, if we get there, what I would like to see is that we do not lose track of the abuse of trust in these intimate settings, and how we see that this has political dimensions. It has dimensions for the prospects of children and the lives of women. This is the first area where I want to talk about trust and its meaning in COVID times in intimate settings. The second thing I want to talk about is trust in the informational setting. So it is absolutely familiar to everyone that medical misinformation has spread very, very widely during the coronavirus pandemic. It's contributed to much higher COVID death rates amongst the unvaccinated. It has also affected the personal sphere, causing frayed relationships between friends and family members who have opposing views about this. This illustrates a problem that we have already had, and it's the problem that Honora O'Neill talked about when she talked about the lack of trustworthiness in our sources of information, whether that be the media or social media. They found that there was a particular disinformation dozen who were 12 individuals who were the source of most of the world's disinformation about COVID. 59 million people were affected by them or were following them, I understand. I don't do social media, so I'm not very good at keeping track of what exactly this was. But the fact is that what we have here is a structural political issue about the structure of our information distribution, which leads people to make decisions which they then see as personal decisions. So again, we have the entwining of the personal and the political, and people saying it is my individual choice whether to take safety measures, whether to be vaccinated. And one thing that I would like to see in the post-COVID world, if again we get there, is keeping track of the entwining of the personal and the political, the domestic, where abuses of trust are amongst the most serious and amongst the most invisible, and rebuilding trustworthiness in our sources of information, whatever they are, the social media and the media more generally. So here again, we see, as we saw in many periods in the past, that the personal and the political are intertwined, how abuses of trust in COVID times are sources of tragedy that can be invisible, and how abuses of trust can be sources of misinformation, which lead people to take personal choices which have very severe political sides as well, causing tragedies that are unnecessary and which are aspects of a trust and aspects of a trust breakdown which will need rebuilding. The trustworthiness will need rebuilding, and this is not just a matter of personal virtue, it is a matter of the structures that we have, the political structures that we have, by which we have mechanisms for reporting the injustices and harms that occur in the private sphere, and we have mechanisms for ensuring that the information that we receive, especially when it's life and death information, as it has been about COVID, is trustworthy and something that we can build not just on our own, but hand in hand with the institutions that we have as well. Thank you.
Thank you so much. That was really fascinating, a lot to think about and to discuss further as well. So our last speaker today is Frank Snowden, who's Andrew Downey Orrick Professor Emeritus of History and Philosophy at the History and Philosophy of Medicine at Yale University. His books include Naples in the Time of Cholera and The Conquest of Malaria, Italy, 1900 to 1962. This book was awarded numerous prizes, including from the American Historical Association on the best work on Italy in any period, and the Welsh Medal from the American Association for the History of Medicine. His most recent book is Epidemics and Society from the Black Death to the Present. And so Frank is going to be talking today on pandemic disease and mental health. So in your own time, Frank.
Oh, thank you very much. And thank you for inviting me to be part of this very interesting conversation. I accept entirely the view that it's not a matter for historians to violate their oath of office by writing the history of the future. And in fact, that's not what I want to do today, to make a model or a prediction of where we're heading. But I do think that history, another danger in addition to the misuse of history, is the danger of amnesia. And it seems to me that the past experience of human beings with pandemic disease is much overlooked to our cost. And what I think we can extract from that record is not a model for the future, but it can contribute constructively to what I might call our worry list, flashing yellow lights. And I think those are quite productive for us, and we ignore them at our cost. So I wanted to deal, and I also wanted to stress that I want to talk about mental health because that seems one of the very bright flashing red lights of the past, but I am not either a neurologist or a psychiatrist. So I want to talk about it from a historical perspective, and I'll begin with something very speculative, which has to do with the bubonic plague. And I believe at that, well, obviously at that time, there wasn't a field of psychology or of psychiatric diagnosis. And so it's impossible to discuss with any certainty to what extent people were affected in their mental health as well as their physical health by the bubonic plague. But I do believe that it's worth thinking about, for example, Shakespeare's tragedies, and especially the later ones, Shakespeare having experienced a number of waves of bubonic plague and having had his own life disrupted by it, and plague playing a very major, often neglected role in his work. I believe we can think that it's possible that Macbeth and King Lear, for example, are, among other things, I don't want to be reductionist here, but that among other things are a portrayal of the mental landscape of a post or ongoing bubonic plague life. I think that might be also one way of looking at Bruegel's famous painting, The Triumph of Death. And we know that from Defoe that he discusses how people frequently hurled themselves into the Thames after being inflicted with the plague. Again, clearly not a sign of mental well-being. We know too from that other diseases definitely affect mental health. Syphilis, for example, with tertiary syphilis having filled up the insane asylums when they were founded from the late 18th century. We know that malaria can lead to cachexia and a kind of indifference to one's surrounding. The Spanish influenza from the 18th century, people and physicians talked about the sequelae of influenza that included what they called at the time post-influenzal psychoses. And we know that after the Spanish influenza of 1918 to 1920, that there was, in fact, a new psychiatric diagnosis of dementia precox as resulting from syphilis, and that it filled psychiatric wards during the 1920s with former influenza sufferers. We know too from SARS in the 2003 Hong Kong outbreak that there have been retrospective or current studies have shown that there's been a persistent trail of psychiatric illness among both patients and healthcare personnel who in 2015 to 17 were still under psychiatric care and were still being medicated or receiving counseling for depression, panic attacks, suicidal ideations, and insomnia. We know too from MERS in South Korea in 2015, when 2 weeks of isolation were imposed, that retrospective studies have shown that of some 1,600 patients, that they continued to show symptoms of anxiety, sleep disorders, and what is diagnosed as intermittent explosive disorder. I think that we'd call it irrational and disproportionate anger. With COVID-19, we also know, and you have already brought out a number of great stressors. One could list them again just very quickly, such as isolation, grief at personal loss, job loss and economic insecurity, the removal or destruction of support networks, confusing and contradictory public health guidance, infringements of personal liberty, school closures, lack of health care work, the experience of healthcare workers and essential service providers, the fear of severe illness and death, all of those and much more. And there's evidence of a profound mental health impact. As we've just heard, this included abuse in the private sphere, substance abuse, alcohol and opioids rising at rates that are off the charts, a rise in suicides, surges in road traffic accidents and deaths, Patients after ICU experience often have delirium and loss of memory and executive function. And it's now been studied that the sedatives administered in ICUs, like lorazepam, have as one of their side effects delirium. We've seen attacks on flight attendants on airlines, report of tsunamis of antisocial behavior in schools. 90% of the therapists surveyed in Psychology Today in the United States report a surge in calls for appointments by first-time patients that have doubled since over pre-pandemic levels. What's also been demonstrated, and this is more recent, still speculative, it's interesting what we're still learning about COVID, and I think that is also a lesson for us about the dangers of hubris in terms of what we know and don't know about of new and woeful disease. We now see that it's well known that there's also physical injury to the brain and the central nervous system, in addition to the psychological factors. Researchers at Oxford and elsewhere have used brain imaging, and in it they have detected in recovered COVID patients reduced brain volume and damage to brain structures, particularly neurons and glial cells. Glial cells were thought to be, I guess the word comes from the Greek for glue, and they were meant to be thought of as just the packing material in the brain, holding everything together. It now turns out that neurologists are discovering that they have numerous and much more important functions, and so their destruction during COVID actually has long-term lasting effects on the brain itself. There's been brain inflammation. We know also that some of the symptoms of long COVID actually suggest brain fog, as it's called, again, an indicator of lack of mental well-being. There's also been an array of studies of the mechanisms that might be involved, that, for example, it's thought that there's a degenerative spread of particles of the virus via the olfactory pathways to the central nervous system, and that this allows the virus actually to reach the central nervous system and to cause dysfunction there. There's been a lot of medical literature on what's called the fetal origins of adult disease, which have demonstrated, again, this has been a major new understanding of genetics. That is, it used to be thought that fetal genes were stationary and we got what was inherited from the past, from our parents. In fact, it's now known that the genes are plastic and are affected by their environmental factors even during pregnancy. That is to say that traumatic or disease impacts upon the pregnant mother can also create long-term developmental dysregulations in the fetus, and therefore affect developmental ways, development in ways for the low birth weight and premature births that cause long-term learning disabilities, low productivity, low economic yield. And there's especially worrying the fact that their impact may be multi-generational, not only from mother to child, but also for child to the next generation. So it may well be that we need to think in terms of COVID as something that even if we deal with the physical disease, it may have long-lasting psychological and mental implications that I don't think our society discusses adequately, or that we have the structures to deal with. So this leads me to think, what about might be possible policy implications? In the first place, I think in the immediate world, there needs to be much more long-term follow-up care, including access to mental health providers. There needs to be a centrality and new urgency on the need to vaccinate pregnant women. That seems to be a very important legacy or new revelation of this new understanding. That this issue, I think, also needs to inform the decision about, say, school closures or openings. I don't think that the calculation has been done, but we need to ask the question whether there's more risk than anyone thought in opening schools, because it exposes children to long-term mental health risks, and that hasn't been adequately examined before schools were reopened. I know closing also has psychological complications, but it's a weighing matter, isn't it? Then I think we need to reevaluate vaccines. Now, I'm emphatically not an anti-vaccinationist. I'm fully vaccinated and boosted, and I believe entirely in the importance of vaccination, but I do have reservations about vaccines if we think of them as a magic bullet and a standalone strategy for dealing with COVID, which is very complex, by dealing with it with a single technological intervention. And so I would believe, as I was saying at the outset, that we need to have less hubris about thinking that we need only to be concerned about hospitalization for physical reasons and death as the only worries we have as outcomes of infection, when it's now becoming apparent that even mild infections, and mild infections even in children, can lead to very severe long-term mental health complications. So I think that vaccines don't begin to address that issue. There also seem to me longer-term policy implications, and I'll just mention a couple that come immediately to mind. One is that, as was suggested earlier, we need to think about the nature of medicine and public health and the need to move away from a narrow emergency response focus on physical health and, as I say, emergency response, to a priority on well-being and not just illness. And that well-being should also include mental well-being, and it should include more stress on preventive measures and not just responding like a fire brigade to a conflagration. There needs to be adequate support for healthcare providers as well as patients, something that was woefully lacking during this. And healthcare providers have also been profoundly affected in terms of their mental health. And then I think we need to think about research funding on mental health and neurology as a major priority going forward, because the past history of epidemics, I think here we also see a flashing yellow light, which is, it seems to be, as Dr. Tedros of the World Health Organization said, the prior history of funding for public health measures goes through cycles of feast and famine. In the immediate aftermath of SARS, there was a burst of public spending, the same after avian flu and after Ebola, but within a year or two, there was a return to business as normal and cost cutting and other priorities. And that's extremely important because COVID hasn't gone anywhere. It may not ever go anywhere. And we also need to be prepared not only for new surges of COVID, but other likely viral epidemics. And so we should be certain as a social priority to include mental health care in any plans going forward for the immediate or foreseeable future.
Thank you very much indeed. It's been incredibly rich, even so far. And one thing I should remind everyone in the audience: if you'd like to ask a question, do use either the Q&A function or the chat function. So that what I wanted to do in the meantime is just almost to get us to reflect a little bit on what some of the things that each other have said. So that maybe if I start from a almost a question that I've worried about a lot as a sort of philosopher, trying to think about, should I say anything at this point now, which is going to, what's the right time? Is this the right time to reflect on what can be learnt either historically or philosophically from the pandemic? Are we still too close to it, or alternatively, are we in danger of missing our opportunity, as it were? That will the world have moved on, and then people won't be interested in COVID anymore by the time we've written our big book about it? So that, do you think this is the right time to be having this conversation from your perspective, either as a historian or a philosopher?
Very interesting question. I'll dive in first, if that's all right, just to say, I don't think there's ever a wrong time. And I think that there is a practical issue, however, that I think is very important, which is that one of the features of pandemic disease, that this could be different, but certainly past experience warns us that there's a human tendency to want to forget what has been terribly unpleasant. And that I think that if we don't, if the world doesn't, I don't mean I mean us as everyone, if there isn't a focus on lessons, and when there won't be the political will, if people are no longer interested in COVID, to be prepared for what might happen, say, 10 years from now. And so I think that it's imperative that people discuss, there be large-scale public discussion of how to make our world safer, how to be better prepared, how not to repeat the mistakes that we made this time, and be aware, more modest. And I think that we have I think one of the lessons of this pandemic also has been the way in which we have been, scientists have talked about a new disease as if they already understood it far too soon. And I think that the stress on vaccines and efficacy and the avoidance of hospitalization and severe disease as the only preoccupations, I think that's a good sign of how we need not to draw lessons too soon and be certain of them. So that's a caveat to the point that I think we need to think now, because we won't have a better time, but to realize that thinking now does have its dangers, in that this is still a very poorly understood disease, and we should always keep that in mind.
Thanks. Did anyone else want to come in on that? Yeah, Ray.
I agree that it's a good time now to think about what we could learn, again, without being dogmatic, and there's still a lot of wait and see about it. One thing that the pandemic has shown is a set of dangers and how they can be exacerbated and lead to tragedies that people hadn't even thought of. Another thing that COVID has shown us, which is not something any of us have talked about, is it shows us what's possible. So it's possible to work at home much more than people realized, and that might be a good thing that might keep going in future. It's possible to drastically restrict the amount of travel that we do, with really good benefits for the environment. And as we're facing the climate emergency, that proof of possibility is going to be something to bear in mind. So while it's still fresh in our minds, it is a time to think about what the lessons are, and I'm sure there are many others.
And the one thing I would just add is, certainly I entirely agree with what's been said about the importance of humility and keeping an eye out for hubris. It does create a dilemma I think for academics, like interacting with the media. So when you get a call from reporters and they say, what do you think? And if you say one thing and then start to say, well, but of course, we have so much uncertainty, we can't really predict that. They start to wonder, why am I talking to you if you're not willing to say anything without immediately qualifying it and explaining how uncertain you are? And so I don't know what's the best approach. If you're trying to intervene in the public sphere, they want you to intervene with confidence. As Frank had said, we should all be wary of excessive confidence because many people have been burned by making comments early on that they subsequently regret, myself included. So I don't know how you deal with that. How do you convey complexity and uncertainty, but still expect a public audience?
I think that's an extremely good question. I wish I had a better answer to that. I'm afraid I don't, but I think you succinctly stated what seems to be almost the central challenge for anybody wanting to intervene responsibly in a world in which other people are, who are quite willing to go on Twitter or anywhere else and say things that are irresponsible, and that to the extent that journalists take, as it were, displayed confidence as a sign of newsworthiness, then it creates a real difficulty for academics. One thing I wanted to pass on to, because I wasn't sure whether there's a sort of disagreement amongst some of you, or whether it's just differences of emphasis about these sort of questions that came out particularly strongly in what Alexander said, and maybe partly in what Ray said and what Frank said. I was questioning, well, how devastating has the pandemic actually been, and how devastating would it have been if our governments had adopted different policies? Because one of the challenges has been that on the one hand, well, it seemed like we had this unprecedented disease, and if we didn't take some quite drastic measures, then something very, very, very bad was going to happen. Then we took certain measures, and then it seems that those measures themselves had at least very bad effects in various sorts of ways, in some of the ways in which Ray mentioned in terms of sort of rise of domestic violence and so on, and the effects on education, and the things that Alexander mentioned about almost the sheer sort of financial costs of what we've done. And so that, I was a bit unsure after all of your excellent contributions, think about, well, as well, did we adopt roughly the right policies? Or if not, what should we have done instead?
Please go ahead, Ray.
I completely share your frustration about that impossible counterfactual question. And this is one of the things I had said early on that I regretted. When I was writing in early March in 2020, I said, look, if you look at human history, epidemics that kill more than 1 million people are exceedingly rare. You can count them on one hand or two hands, depending on how you count. And what are the odds that we're in one right now? It's like, well, we are. The official estimates are that 6 million people have died, and everyone assumes that's a vast undercount, not just in places like India, but also in the United States for a variety of reasons. The COVID death counts likely miss a lot of deaths. Would it have been different had we done nothing? This gets back to the complexity problem, and I think data analysts will be looking at this data for generations to come. Because places like within Europe, different countries did different things and had different outcomes. Within the US, there were dramatically different policies pursued by different of the 50 states. And if people are able to find good enough data, potentially you could sort that out. One of the things that's been frustrating for people in the Northeastern United States, where Frank and I are, is many people in that part of the country felt like we did the responsible thing. We were enthusiastic about vaccination. We wore masks. We were much more compliant citizens than our counterparts in places like Florida and Texas. We don't have a lot to show for it, though, if you look in terms of COVID cases or mortality rates. COVID wasn't a catastrophe in Florida or Texas compared to New York, even though if you look at state policies, it ought to have been. And so you're faced with a situation of saying, well, all these conscientious things that we did in the liberal Northeast didn't work. Or you say that, well, the epidemic was incredibly complicated. Yes, it wasn't worse in New York. It wasn't better in New York than it was in Texas, but it would have been so much worse in New York if New York hadn't done what it had done. And there's just no way to resolve that question that I'm aware of. But again, as I said, I think this will preoccupy a generation of data analysts. And maybe people will get clarity. That's hard to imagine.
Yeah, Ray.
Yeah, just following up from that point, I think, I mean, the philosopher J.S. Mill talked about how it was important for democracies to have experiments in living. And one thing that is very striking about COVID is that, as you just said, we've had so many different approaches in different countries. And I feel really grateful that in the UK, whatever terrible things have happened, the level of relative trust in the National Health Service has been one of the public goods that we have that many other countries have not had. But it would be really interesting to compare what's gone on in the various different approaches, not just from an epidemiological point of view, but also from a political point of view. How important is it to have institutions which command trust and need to be valued, like the NHS perhaps, and how important is it to approach pandemics in ways which do not promote polarization, which has happened in so many other countries where it is big, it's, you know, your approach to COVID has been like wearing a political badge of some kind, whichever approach you have. It shouldn't be like that. We need to think much more sensibly in a democracy about things like this. And I think that having a good look at how things have worked out might bring a little bit of humility to that question as well.
Yeah, did you want to come in, Alexander? Yeah.
Just briefly, yeah, it's interesting. I mean, these comparisons are going to be very difficult to make, and it may, as David says, take some time, and you know, we may or may not get helpful answers. So in the European context, Sweden is the particular example of a nation that took, you know, a much less invasive approach, but yeah. People disagree about whether it was a success or not, or to what degree it was a success and what that success was due to. And yeah, it's going to be extremely difficult to work that one. I have my own views, but there will be, you know, when I say them, other people will have really opposite views about, you know, whether it was good, and if so, why it was. But still, we should. I think we should try our best. But I think, yeah, perhaps the answer is that there was no, there's no good outcome, right? Yeah, there's nothing that was going to make this not bad news. The question is where the bad news arises, and then to what degree, and then the counterfactual questions come up. So I think that what Frank was saying about mental health was really interesting in this respect, because it seemed that was interesting to know what how Frank feels about this sort of way of sort of taxonomizing the kinds of mental health effects, because it seems that there were mental health effects that Frank, you were talking about, that were the direct effects of having the disease. Then there were effects of being in a not direct effects of the disease, but being in a world in a pandemic. Whether that's your anxiety about getting the disease, or being an overworked health worker in a hospital that's that's full of dying people. Yeah, that's the effect of the disease, but as it were indirectly. But then there are the other things which were the effects of our policies to combat the disease: isolation, domestic and sexual abuse, and so forth. And it seems that, as it were, that depending on what policies one's pursued, that some of these effects might be greater, and others less. So a more draconian policy might have reduced the number of cases, and therefore the number of instances of mental health from having the disease, but might increase the mental health problems from sort of people being isolated, at home, domestic abuse, and so forth. And I was just wondering whether Frank had a sort of view about whether that's a helpful way of thinking about these three kinds of case: direct effects, indirect effects of the disease, and the effects of the policies, and whether you have a view about, in the current pandemic, how these you quantify against each other.
Yes, that's an interesting question, and one that's actually, like so many, impossible to answer, at least at the moment. And one of the reasons for that is that it's impossible to quantify how many of, we can see the results, but we don't know in all cases with any certainty. There are no statistics for how many can be attributed to which of the three different taxonomical categories you've put forward. So I think that we're stuck with the fact of a lot of uncertainty, but that we need to be aware that all three exist, have major impacts, and that policy needs to be informed by an awareness and an expectation that if we do have lockdowns, it will have major negative effects. If we have schools open and children in them during the pandemic of COVID-19, there will be long-term also negative. You have to weigh up the two of the actual impact of the disease on their brains and central nervous system. I guess part of it is knowing how widespread, what is the incidence of these different factors, and that there's not any clarity, and there's not even clarity about the definitions of the different terms. So I think we're a long way from being able to have a very definitive answer. And I think we need to be aware of charlatans who pretend that they do have a definitive answer to that question. But I think if someone is pretending to solve the issue and claiming knowledge and certainty, I think that's a real warning sign of a politician we don't want to have in office. So I suppose that would be my answer, which is, I guess, partly a cop-out. But I think, and this goes back to what David was saying too, which is that I don't think that it's wrong to have uncertainty in public discussions. I think that's actually honesty. And I think that's a quality that's in, unfortunately, short supply in our public discourse about these matters. And I think that the public would be much better off and would, I think it would go some way to restoring what Ray has been talking about of trust. If politicians and people who are, experts were talking about what isn't known still and why are policies being adopted, and it's with this expectation, and we're all, it's even, I guess every medical, having been married to a physician who said that every case that she treated was actually in a way an experiment. And I feel maybe that's also true of public health. And so it's not a matter of saying, I know definitively, but rather saying, this is on the basis of the available evidence, this is what I would recommend and expect. That's, I think, the best one can do. But I think to do that and to qualify it in that way is restoring trust and resisting the power that is the pressure from the media for what I think is unhealthy, which is a catchy soundbite.
Yeah, I think that was so rich and interesting. I want to pass on to thinking a bit more about trust, and maybe I wanted to frame it partly in response to some of the things that Alexander mentioned. So that I think Alexander's, I think, sort of rightly pointed out that we, certainly in the UK, and I suspect in many other countries as well, that if you look at the cost per life saved, it looks quite high on one kind of measure. But the one thing that really popped into my head at the time you were saying that is some research done quite in another bit of philosophy by Amartya Sen and Jean Drèze. And they asked the question, well, why is it that you tend to get famines in autocracies and dictatorships, but not in democracies? And their kind of obvious answer to that is, well, you just couldn't survive as a democratic government if it becomes known that you're willing to let your citizens starve to death. You'd be out of your ear at the earliest opportunity. And everything about the way that a democracy is structured, about some public reason, the ability to hold politicians to account, is to make sure that politicians are not able to sacrifice some individuals for others. And so that it seems that there's a sort of fundamental question about almost what do you think that the state is for? Because I'm just trying to imagine almost what it would be like to have a conversation with your public at that moment as a politician, to say, well, look, well, we've got this menu of choices, like say, well, if we do nothing, 500,000 people are going to die in the UK. We could bring that down to maybe 50 or 100,000, but that's going to cost a lot of money. But we don't, we've looked at the figures and we don't think it's worth saving those lives. I can't, it's difficult, even if that's sort of what governments sometimes do, it's difficult to imagine having that sort of conversation with the public and maintaining trust, because in a moment of emergency, it may be that people want to feel that they want the kind of government that's got their backs, even if it means that it's expensive later on. Or at least that's my hunch. I don't know. It may be that you would disagree with me, but I think there's an other aspect about this, almost what it is to govern in a way that allows you to maintain trust in the context of a pandemic disease.
In that context, could we say that maybe that is what you're saying is actually what the social contract is all about? That is to say, the state is there for a purpose, and the purpose is to keep life from being nasty, brutish, and short. And so if you have a pandemic and the state does nothing, it seems to me that that would be a total breakdown of the social contract, and that the result of that would be pandemonium and maximizing all the possible worst case scenarios. That would be my guess of what the result of that would be.
That was the worry I had. So that, yeah, my assumption was that governments had done the right thing, even though it turned out to be extraordinarily expensive. But having heard Alexander's argument, I guess maybe he's asking us to think about it, or it's maybe tricky to know almost at the moment at which you could do those sort of calculations. Because one of the things that became apparent in the UK is just how indeterminate, how difficult that governments were finding it to actually sort of put a number on things. There was a moment when we had a budget and our Chancellor of the Exchequer set out how much they're going to set aside for COVID. They said it's going to be 18 billion. They came back about 10 days later, and then they said, well, we need 10 times more than that or more. And they at that stage, they realized they had a furlough scheme. So that clearly, despite the fact they had 1,000 or more people in the Bank of England, incredibly good economists, they had no idea what they were doing. The fact that you were out by a factor of 10 within a week. But yeah, I'll come to David.
One of the issues that comes up in those calculations, and this is something that became clear now about 20 years ago, when there were a major round of debates about whether it was cost-effective to treat HIV in the global South. There was a very robust cost-effective analysis published by researchers at University of California at San Francisco, and said, look, we have these preventive techniques, we have these treatment techniques. If you do the analysis, prevention is 28 times as cost-effective as treatment. So therefore, in resource-poor countries, you should invest all of your resources in prevention. And that position was furiously attacked by some of my colleagues, most famously Paul Farmer, who pointed out two issues. He said, one is the issue of the malleability of cost. At the time, HIV medicines cost $20,000 per person per year. That number is now about $50, and that obviously has a gargantuan impact on a cost-effectiveness analysis. And the other thing he said you really don't know is, how do you actually fully capture the benefit of any kind of policy intervention? And so what he asserted at the time, which was later shown to be true, was that if you treat someone with HIV, you render them non-infectious, and so they're no longer spreading the disease. And so it's not just a question of saving one life, you're also saving the lives of all the people that person would potentially have infected, which is a very hard number to count and predict. And so there's this fundamental indeterminacy in those kinds of cost-benefit analyses. And I assume there's a similar problem. Alexander may have an answer for this, but when you talk about how much money was spent per life saved for COVID, what we don't know is how many additional deaths there would have been had nothing been done. Is that a big number? Is that a small number? And should you figure out, as part of your calculations, or try to figure out how many additional lives would have been lost had nothing been done? And then should that figure into your cost calculation? How many lives have been saved by vaccination campaigns? I don't think we really have an honest answer to that question. people who have been vaccinated can still transmit. They probably transmit less than they would have been had they not been vaccinated. And so the denominator in a lot of those calculations is unclear. And I assume that has a big impact on what the numbers actually look like, which would then have a big impact on the policy evaluation of those different scenarios.
Yeah, do come in, Alexander.
Yeah, I think these are all important and good points. I mean, part of what I wanted to do was just to be slightly rhetorical in the sense of just getting us, just throwing out those numbers gets us to think about what it is that we're doing and why we're doing it. And even if, as it were, we conclude the next time around we probably wouldn't do things much more differently, at least we're doing it with having some reflection, rather than it just being this emergency response, and where we're not even going to think about these other things until later, and then we'll deal with them separately. So I agree. I mean, a different disease, it will be very difficult to make these predictions. Although, who knows whether Neil Ferguson, who made the predictions which changed our government's policy, was right in predicting that if we'd done absolutely nothing, there would have been 510,000 deaths. Yeah, I mean, I think some people say that's an overestimate, but others, who knows, it might have been an underestimate. But James's question is interesting. But how would one have this conversation in the public sphere? I mean, it's it's difficult. I'm not quite sure how one would, but I'd like to try at least. One would say, look, one thing to ask is, if we were going to recoup these costs by cuts in our health budget, it's say by 10% over the next 15 years. People say, oh, yeah, that doesn't 10%. That doesn't sound too bad. And then you say, well, actually, that's what this is what would happen if we did 10% less on our health budget for 15 years, and you, well, it'd be 25 years rather, not 15, or more if you compound interest. The effects of that will be huge when you start to spell it out. And I think but on the other hand, we don't really have these discussions very effectively about government expenditure in general. So I agree with James. It would be very difficult to have this and this conversation. But I suspect that this is just another aspect of what you David and Frank were referring to earlier about, and Didi Ray about it. The quality of public debate on issues where there's uncertainty and all these other things is very low, and this is just another area where these complex issues, it's difficult to have public discussions about them given the nature of the media and so forth.
Yeah. Thanks. So I'll come to Ray in a moment. I just wanted to insert a brief comment from myself, because I found what Alexander said really interesting. And one of the things I was trying to work out, and it may be just another of these imponderables, is almost sort of, even if you were going to try hard to have a good conversation with the public about how to make these sorts of decisions, there's a question almost about when you should have that conversation, because my sense that probably nobody had any idea. I mean, I've been thinking about kind of public health. I've been teaching on sort of ethics of epics and pandemics for years, but I had no idea that it was going to be like what it was when it happened. So the idea of trying to have a conversation with people, as it were, in peacetime about what should happen, they're probably not going to say the same thing as they would do in the midst of a pandemic. But obviously, in the middle of a pandemic, it's probably about the worst time to try and have a national level conversation about the value that we should put on saving a life. So it may be just a really difficult and tricky set of questions to work through, even to work out even if you're trying to just ask to answer a sort of sociological question about what's the sort of average answer to this question about how much people will be willing to save a life. That may be quite sort of the average answer may shift quite significantly depending on whether you ask them in the context of a pandemic or sort of peacetime, as it were. So yeah, so I wanted to come to Ray, as you've had your hand up for a while. So apologies for the wait.
No, that's okay. I think what you said was very apt, James. And I just wanted to say there's another conversation there too, which is the one that you have when you run Alexander's comparison in the other direction, and you just say what COVID shows is that we care enormously about having a public health service that is in the UK good enough to be able to save lives even at this cost. And so what does that mean about what we should be investing in the public health service for all of these other things that we're not doing enough of? So take the same comparison and just run it in reverse and say this shows what we care about, and this shows where we need to invest in future.
Yeah, I think that's a good way forward. So that, yeah, it's about a year or so ago, I was asked exactly this Alexander's question by a journalist for one of the UK newspapers, The Observer, and it was a hard question. I talked about 45 minutes, and she used about 2 sentences of what I've said. But luckily, she used the right 2 sentences. But basically, the thing that I said, which I thought was the essence of it, say, well, you just have to think as a society, what sorts of things are so unconscionable you think they should never happen, and that if what you're trying to avoid is something that is so unconscionable it should never happen, you know, as Frank described as the breaking out of pandemonium, then you need to think, well, we just throw everything we got at it, you know, and certainly at the beginning it seemed like we were in one of those certain situations. It may be that in retrospect that was the wrong judgment, but it seemed like that was where we were, sort of, you know, about sort of March 2020. It seemed, and it may be just the way that, you know, the media framed it, but it seemed like we were in a potentially sort of existential situation for society, where it became a matter of thinking, well, you know, politicians, publics as well, were aware that this might define how the society thought of itself for a generation or more. And at that moment, I think effectively people said, well, we want to be the kind of society which will kind of defend the lives of 80-year-olds, rather than the society which says that's just too expensive. Yeah,
very, very briefly. Yeah, I think Ray's absolutely right on that point, and that's certainly one of the take homes I take from this kind of thinking is that we, you know, that it maintains a strong case for much greater public expenditure on health, but to do the other things that, yeah, to do all these other things. I think that's absolutely right. But I mean, I gave, and I said something very similar to that when I gave a public lecture version of what I've just said a few months ago. But what was interesting also from that was that I got a sense that this sort of, that it was actually middle-aged people who were much more raising the sort of the objections. This would be unconscionable kind of society if we allowed our 80-year-olds to die. I got much more favorable response from the retired people, the 70, 80-year-olds actually, and they were saying, yeah, I'm much more likely to agree with me and say, well, actually, yeah, to them it made sense for them not to be the priority. So it's interesting how that was different.
Yeah, I wanted to see whether anybody wanted to pick up on some of the other elements about sort of trust and trustworthiness that we mentioned, because that Ray made sort of good use of kind of now sort of relatively well-known work by, you know, Baroness and Nora O'Neill, sort of, you know, trying to make the distinction between trust and trustworthiness, and saying, well, what really matters in public life is trustworthiness. And I'd always sort of believed Nora O'Neill on that, but midway through the pandemic, I started to wonder, well, is she actually right about it? Because one thing that we seem to face with lots of cases where, as it were, trustworthy public health information was being produced, but people just weren't buying it, or that you think about the rise or the nature of vaccine skepticism and hesitancy, you became aware that sort of, as it were, that, you know, the tests for the vaccines were done kind of to appropriate standards. There's no sort of reason in scientific terms for people to think that they were likely to be dangerous, or that Bill Gates had put chips in them or any of the other things. But nonetheless, many people just didn't buy it. They didn't trust it nonetheless. And so at that moment, it did seem that, as it were, sure, trustworthiness really mattered, but the fact that it really mattered, the fact that people just didn't trust things that were, you know, perhaps from an objective perspective, actually trustworthy. Yeah, Ray.
Right. That's right. And that's because of the sources of misinformation that was being fed to them for profit by other sources of testimony, if you like, by the, I don't know, whether by those dozen that I mentioned before that were written up, or by whatever social media sources. And I do agree with you that there are two sorts of problems. There's the problems of the untrustworthy who are being wrongly trusted, and there's the problem of the trustworthy who are being wrongly mistrusted. And you've highlighted the second of those, James, and that's absolutely right. But the reason is for the first problem that I mean, if it were not for sources of skepticism that, you know, work like Descartes' deceiving demon hypothesis to sort of put a shadow of doubt over everything that you've hitherto trusted, then that is the destruction of a very important public good, which is the existence of justified trust in trustworthy institutions.
Yeah, Alexander.
Sorry to come back, but I think there are other things that play as well in certain, let's call it sort of marginalized communities, whether ethnic minorities or otherwise socially and economically disadvantaged communities in the UK. First of all, levels of trust in the government generally are not as high, and possibly for good reason, and indeed not as high in the health service as they would be for you and I, and possibly for good reasons there, because we do know that health outcomes are worse for people in these communities, and they're aware of this, and so it may well be that the relevant institutions, governmental broadly and NHS included, it's not possibly from their perspective not quite as trustworthy as we might like to think, and it's not simply misinformation that makes people not trust them. And the way I've tried to get myself into thinking about people who are vaccine hesitant, rather than just write them off, sort of immediate responses, oh, because you're just being irrational or being misinformed by listening to these bad sources, just to think, actually, I suspect their attitude towards the vaccine is rather what mine would be if I were offered the Sputnik vaccine, right? If I'd lived in Hungary and being offered the Russian Sputnik vaccine, I would have been hesitant, right? I would definitely not have been that confident in taking it. Yeah, other people tell me it's perfectly fine now, but I still would have had that kind of anxiety, and I think that's the sort of thing that some communities in the UK have towards our vaccine.
Thanks, that's helpful. Can I come to David?
Yeah, and just to follow up on that, there's now been a lot of work both by journalists and social scientists in the United States interviewing people who haven't been vaccinated, trying to understand, what it is that's been driving that. And a lot of these people will say they bristle at being labeled as anti-vax or vaccine hesitant, again, as if they were somehow irrational. And I heard a fascinating interview with a woman yesterday who basically made it sound like that it was officials' fault for having not made the vaccine seem desirable enough. She wasn't opposed to vaccines. She didn't just trust the vaccines, but she just wasn't motivated to take it. And she really put the burden on the healthcare system that they needed to do a better job making this something that she wanted, and maybe having the ability to have more frequent visits with her doctors, or maybe if she came to the clinic, if the clinic also provided free lunch, then maybe then she would have taken the vaccine, which was so interesting because those aren't the kinds of things that the vaccine advocates have been pushing, which suggests that there's a disconnect between what the public health officials think people want and what people themselves actually do want. Because it's been so confusing. Maybe the US has had this worse than some other places, but there was a lot of discussion about why it is that so many people who refused the vaccine or who hadn't been vaccinated when they were admitted to the hospital, were still seeking treatment with hydroxychloroquine or ivermectin. It's like, why would you trust those, but then not trust the vaccine? And some of this is from misinformation, but some of it must be driven by other factors. And it's created this funny situation now for senior public health officials in the United States, where increasingly the main criteria for should you be appointed to a prominent position is how good you are as a communicator. And so, for instance, much of the discussion about the current director of the Centers for Disease Control, Rochelle Walensky, isn't about how smart she is or how well she understands COVID, but all the conversation is about, is she a good communicator? And Tony Fauci was criticized for his confusing communications about masking. And it'll be interesting to see going forward to what extent those sorts of positions that used to be considered technical scientific positions increasingly are considered public relations positions, and a different kind of expert is put into those roles in pursuit of public health goals. Now, it shouldn't be a surprise to anyone that public health campaigns require good marketing. Again, that's been true forever. It'll just be interesting to see how far governments go in putting the marketers into those roles instead of the technical experts.
Oh, that's a fascinating question. I mean, certainly in the UK, it was very interesting as the government instituted a number of basically sort of press conferences every day, and there'd be Boris Johnson or another minister as the politician there, sort of flanked by the scientific advisors. And it's an incredibly difficult job for the scientific advisors, as basically even when they thought the government was making the wrong move, or when they advised, for example, that they should be locked down, the government was dragging its feet, they couldn't sort of in any way say that the politicians had done the wrong thing. So that you can see that just from their body language, and there's some of them were better than others. There's one of the deputy chief medical officer called Jonathan Van Tam, who somehow managed to be more honest than the other people. He was thought to be a much better communicator because he made use of a lot of analogies, often to do with weird analogies to do with playing football or going into a train. But somehow he sort of connected with people, and partly because he talked like an ordinary person, people felt that they sort of believed him. And so he sort of gradually became a kind of face of the government's vaccination campaign, partly because he was the only one of those top people who wasn't sort of a white, so obviously middle class man. He was and he had that sense it was incredibly important. Yeah, I think you're right. It does seem to be a really important element. If what you're if as it were, it's not the vaccine doesn't save lives by merely being in a jar. It's only by being in people's arms, and in as it were, the ability to persuade people seems to be a really important element of public health. Obviously, there may be ethical limits on how we think people should be persuaded. Yeah, I think Frank.
Well, I did want to say something to that, which is I feel it's not the problem. I take your point, David, about the marketing, and we don't really want marketers driving public health response. But what does seem to me that there's a deeper problem, which is I think when the discussion of the composition of SAGE came up, strikes at what I think is a profound problem, which is that are we not making a serious mistake in thinking that public health and medicine can be left to doctors and public health officials? Isn't this really a social problem and not simply a medical one? And it's very distressing, I feel, to see the degree to which only medical personnel have been consulted in terms of what should be provided. And I think that there are real lessons that can be taken from some of the worst possible environments for public health in the slums of Lagos, for example, and Nairobi, where in fact what was discovered was that there was absolutely no way in which what health experts from the metropolis were saying was applicable to their situation. You actually couldn't follow social distancing and hand washing in a Lagos slum. It had no meaning. And so what was done was something that hadn't been done before, which was to have community groups talking and discussing about what their conditions were and how the same goals could be met in different ways. And that takes me back also to the anti-vaccination issue. And I think that we do a lot of discredit by and worsen the problem by the attitude that the people who are hesitant are all stupid or led by QAnon, whereas there were focus groups, for example, in Africa. This is just one example in African American communities, where the people who were vaccine hesitant were explaining that they had thought long and carefully about it, but they thought that the groups that were the test groups for testing the vaccination didn't include African Americans with their particular problems of pre-existing disease, obesity, and all the rest, and therefore measures that might be a vaccination that was good for, let's say, the white, middle-class, slender male was not actually going to be helpful for these other groups. And pregnant women had this problem as well. And one can understand that. And I think it's worth remembering also the history that if you go back, that anti-vaccinationism isn't just a recent phenomenon. It goes back to the resistance to Edward Jenner, and that there were in the 19th century very rational leading scientists like Alfred Russel Wallace, who was an anti-vaxxer, and he had I think if you were just eliminated all post the knowledge that we've acquired subsequently and put yourself in the position of knowing only what you read and that was available at that time, his arguments seem much more persuasive. And so I think that may be partly true for what needs to be done about vaccine hesitancy, which is to broaden the discussion, to include people from the communities in how this is presented and justified and dealing with the real problems that they have. And I think that it was sort of rolled out the way you might, I don't know, roll out Ford motor vehicles, the vaccine, and expect everyone to welcome them on the receiving end without really reassuring people for their legitimate concerns. Anyway, that's my position on that.
I think we're almost at the end of our time. I wanted to give anybody who sort of felt there's something that they were burning to say and hadn't had an opportunity to say, if there's anything, if anybody has a sort of a last sort of comment or the last thing they wanted to say before we close, then I'll do go ahead. Does anyone have a sort of a closing bon mot or similar? Yeah, David.
The last thing I would say is that in my comments, our focus now is what to do in the end game for COVID. But we do have to remember that COVID is just one disease. Presumably there will be future pandemics. I hope we handle those previously better than we have handled this one, that we've learned from our experience. But as Alexander has suggested, pandemics are just one of the many problems that we face. And there's so many issues, whether it's in the US, the opioid crisis, or mental health crises everywhere, or heart disease, which continues to kill far more people worldwide than COVID ever has. How do we figure out how to get the appropriate priorities and the appropriate resource allocation? As Alexander had said, will be a huge challenge going forward. And I just hope we do learn something from our experience over the past 2 years so that we can do a better job.
And also the issues going even beyond health to the problems that we have addressed that might or might not be health issues at all. They involve loss of income, they involve distribution of domestic labor, they involve sexual violence in the home, and these are not health issues at all. We've learnt all sorts of things from COVID that will apply to health and other areas of health and beyond.
Thank you. So this has been a really rich discussion, and maybe we started from almost despite the fact whether we've got more data than we've ever had on previous pandemics, it's just part of what that was revealed is just the complexity, both at a causal level of what's gone on, why it was that the policies either had some effect or didn't have some effect, but also the ethical complexity as well as realizing that something that we do to reduce one risk can often increase other sorts of risk. as well. And so that maybe if there's one thing to take forward from that, it's maybe a realization that policy needs to be joined up, not just within the health sphere to think about, well, how do we think about the importance of infectious disease compared to other things like cardiac disease, but also much more broadly think about what are the World Health Organization have been arguing for years for the idea of health in all policies, the idea that think about the health effects of your transportation policies, for example, of your policies on food. But maybe one of the things to take forward from the comments that Ray and others have made is almost that we need to think almost about the effects of our health policies on lots of other things that we care about as well. If it turns out that our health policies have bad effects on domestic violence or on social isolation, other sorts of, those are things that we need to be able to take account of as well. So, well, I just wanted to end by thanking you all very much indeed for being a most enjoyable discussion, and well, great chatting to you. Thank you.
Thank you,
James.
Thank you.
Thank you, everyone.
Bye, and thank you.